Good evening, everyone. So that was a great academic session, right? And it feels really good being part of an academic program. And at the outset, I would like to really thank ISA for giving me this opportunity to deliver this talk. And my talk would be not that serious one. So you have to just relax and try to imbibe some important points that I'm trying to mention here. Okay, so let me start. So how many of you have seen this picture? I'm sure that not many. This picture is taken from the initial chapter of Barash, that is occupational health. And this is one of most important pictures in this book. And they have tried to convey the stress that is faced by a young anesthesiologist due to the postponement of life events due to the lengthy study period. We know that the MBBS MD periods are too lengthy. So after completion of MD, it will be around 11 years, probably 10 to 11 years. So you see that the formative life events get overlapped. For example, at the age of around 30, you start the early career cycle. But the thing is that at that time you get married. So this builds up stress. And this is one of the most important cause of stress that is faced by young physicians or surgeons. And you can see that the initial attitude when we join our MBBS times, it will be like you feel that I want it all. And then at a later phase, you feel that, yeah, I can have it. My dreams, I can have it. And at the middle, that is around 40 to 50 years of age, you feel that I have it all. And finally, you realize that maybe I can't have it all. So this is a very interesting and important picture that depicts the life of a young physician. So these are the main three problems that are faced by a young physician. So the three main problems, the one is that it is stress. The second is burnout. And the third is limitation. We will come to that in detail. Now, if you search about anesthesia and stress, you get plenty of articles. And you can make even a book regarding the references of stress and anesthesia. Now, why is this? Because, and what is this due to? So let us see what is the stress syndrome. Stress syndrome has mainly three components. One is the initiating stressors. It can be a health issue, or it can be a family issue, financial issue. That is a one component. That is the initiating stressor. The second is the psychological filters. See, every individual will have a particular way of taking a stressful event. That is known as psychological filter. And the third is a coping mechanism. Every individual will have a certain way to adapt to that stress. Some may go for an outing, some may go for a hangout, or some may go for just a time or just a dinner. The thing is that some may feel really depressed, and he or she may not go out of his home. So it depends. So the coping mechanisms actually depends on individual. So it is highly individualistic. So these are the three components of stress. And you should know that absence of stress is death, as said by a famous psychologist, Hans Selye. Hans Selye is actually pioneer in the field of study of stress. So he says that the absence of stress is death. So a particular minimal amount of stress is a necessity. Have you heard of this law, the Yerkes Dodson Law? It is nothing but it is shows a stress performance curve. Here you can see that the x-axis is the stress and the y-axis is the performance. So a low level of stress is actually beneficial because that stimulates us to do some work. And the highest performance is reached when there is optimal level of stress. And after a particular level, too much stress impacts the performance. So this is what is called as the Yerkes Dodson Law. And why anesthesiology? I said previously that if you search stress and anesthesiology, it will be like you can get a whole number of plenty of articles. Now, why is it so? Because the operating room itself creates a background of chronic low-level stress. And you can see that the hemodynamic instability, or let it be anything, hemodynamic instability, or difficulty in ventilation, desaturation, anything, these are all causes of acute episodes of extreme stress. And unpredictability of work. Sometimes the surgery may go for long and you get stuck in the OT. So unpredictability of work. The fourth is due to that it is a specialty that requires sustained vigilance for long duration. So you have to be like a fully concentrated, a fully vigilant, and that too for long hours. We'll come to that in detail. The third is like any specialty, fear of litigation for malpractice lawsuits. And the most important thing is interpersonal relationship, difficult interpersonal relationship. You morning you get inside the OT, you feel someone whom you doesn't like, and that day is gone, right? So that is one among the most important cause of stress that is interpersonal relationship. The next important thing is burnout. I want to specifically bring in this topic, but the thing is that many of us feel that burnout is just, oh, you feel down. No, it is not like that. It is actually a clinical syndrome. So burnout is nothing but a clinical syndrome characterized by physical and emotional exhaustion, poor judgment, cynicism, guilt, a feeling of ineffectiveness, and a sense of depersonalization. And you have to have that clear borderline between stress and burnout. Stress is actually characterized by over-engagement, while burnout is characterized by disengagement. That word is important. You feel down and you don't feel to do anything. And stress results in a loss of energy, and burnout results in a loss of motivation. And the stress primarily takes a physical toll, and burnout takes an emotional toll. And burnout is accumulation of unchecked stress over long periods. And you can have stress without burnout, but you cannot have burnout without stress. That means unchecked stress for long duration can lead to burnout. The third important thing is limitation. What is this limitation? See, there is a particular term known as impaired physician, and we have definition of impaired physician. An impaired physician is one whose performance as a professional person and as a practitioner of the healing arts is impaired because of either alcoholism, drug abuse, mental illness, senility, or disabling diseases. And even unwillingness or inability to keep up with the current literature and techniques is supposed to be characterized as limitation. So that is why we are conducting these CMEs. So yeah, like that is very important. And there is an important concept called as the aging anesthesiologist. If you refer the standard textbook, you can see the entire topics, certain important topics dedicated for the aging anesthesiologist. And that is a very big topic proper. I'm not going into the detail. And one striking point that I noticed in that section is that, see, after a point of time, you know that your neurocognitive function gradually comes down. And the thing that counts really is your experience. That is your wealth that you gained. But you need to know that experience is not synonymous with expertise. And you should, and that is a thing rightly pointed by an expert, that's Wenger. And he told that experience is not synonymous with expertise. So after a point of time, our neurocognitive function decreases, and we need to accept that. Okay, so that is what I want to highlight. And what are the interventions that we can do? See, if you just check the literature, you have so many interventions that are mentioned, like a crisis management protocol, or just counseling, so much things. But the time-tested interventions are these three. One is proper diet, proper sleep, and exercise. These are the time-tested intervention, and especially for anesthesiology, any recreational activity is found to be really beneficial. Any recreational activity, let it be a music, or it can be a dance, or it can be just reading some other books or playing a musical instrument. And these are found to be really useful. So the first is diet. You should know that the fat is an endocrinology active organ. It is not just a fat. It is just a active, endocrinologically active organ which secretes adipokines, which is responsible for decrease in the peripheral insulin sensitivity, uptake of glucose by muscle, and also it increases hepatic glucose production. So calorie restriction has anti-aging effect. So even a deficit of 500 kilocalorie per day has anti-aging effect. So you should really target a weight loss, and you should maintain the weight loss. Next is exercise. Proper exercise, brisk walking, jogging, at least 10 minutes of exercise can lead to significant reduction in death rate. And you know that During exercise, there is increased expression of GLUT4 and fat CD36. GLUT4 is for absorption of glucose by muscle, and fat CD36 for the absorption of fatty acids by muscles. And we always discuss about the physical problems, emotional problems, mental problems, but we never discuss about sexual problems. And it is found that there is a decrease in nitric oxide levels in blood due to sedentary lifestyle. So this can be improved by exercise. So that is a really important point which we usually hesitate to tell. Sleep, proper 8 hours of sleep is must. But I can understand that during our on-call days or during our duty days, how is it possible to obtain that sleep? So let's hope for some days where adequate number of doctors are available so that everybody would be able to spend at least 8 hours of quality sleep. And sleep experts tell that regularity in the bedtime and regularity of wake-up time is very important for a sleep hygiene. And you should avoid stimulant drugs just before sleep. Strategic napping, at least 45 minutes. It is supposed to be really beneficial. And another important thing is that if you are practicing strategic napping for 90 to 120 minutes, you can have advantage of an entire sleep cycle. So that is what is called a strategic napping. And you should avoid any important procedures being done during this time. That is 2 to 6 a.m. and 2 to 6 p.m. You know that the suprachiasmatic nucleus is a circadian, controls the circadian rhythm, and the circadian dulls happens during this time. So you know to be really careful during that period. Now, what are the qualities that an anesthesiologist is supposed to have? So we have seen these two logos. One is the Indian Society of Anesthesiologists logo, and the other is the American Society of Anesthesiologists. Both have something in common. Have you noticed it? But both have vigilance in common. You can see that vigilance is a center point of attraction. Vigilance is nothing but it is the ability to detect the changes in a stimulus during a prolonged task, and when the subject has no prior knowledge of whether or when any changes might occur. And vigilant tasks are performed at the level of 90% accuracy. That means, you know that suppose if you are vigilantly monitoring a patient with 100% vigilance, even then the level of accuracy is just 90%. So you have that 10% margin of error. Now, another problem with anesthesia is that, see, there are increasing number of monitors, increasing number of alarms and whatnot. So at a point of time, even if you are highly vigilant, you get fatigued and you get distracted due to this alarms. This is known as alarm fatigue. And now there is a tendency towards knowledge-based alarms, where the alarms are integrated and they keep ringing only when it is absolutely necessary. The second important quality might be memory. So, you know, there are two types of memory. You have a retrospective memory and prospective memory. The working memory comes under what is known as retrospective memory. Now, it is used for temporary storage of informations. Like, for example, suppose you are asked to calculate an infusion dose. So suddenly you just calculate and tell. So that is for temporary storage. And it helps to manipulate information and focuses attention. So this is called as working memory, really important for us anesthesiologists. It helps in multitasking and to differentiate between relevant and irrelevant information. But the thing is that it is an extremely limited brain source and it is usually affected by aging. So when attention needs to be divided between two simultaneously happening processes, there is a reduction in performance. And this usually happens during conduct of anesthesia. Suppose if you are ventilating a patient, you feel that the patient is desaturating and some laryngoscope fall down, you feel that you are distracted. Again, the ventilation of the patient comes down. So there is reduction in performance. And if we are all working with this working memory, right? So the thing is that we need to store this information like doses of multiple drugs, ventilation parameters, so many things that has to be taken care of during a period of time. So this leads to chunking of information. The best example of a chunking of information would be this anesthesia record, where you have this so much information, right? Now, the second aspect of memory is a prospective memory. Prospective memory means it's one's ability to remember in the future what to perform. And I have noticed that, see, suppose if you want to administer Vecronium every 20 minutes as a maintenance dose, sometimes you forget to administer at that particular time. You get distracted with something Either it may be a hemodynamic compromise, or it may be surgeon telling you something, or it may be you want to change an IV fluid. So this happens, right? So it is particularly prone to disruption by interruptions. Okay, so prospective memory, one of the important aspect of vigilance is prospective memory. So you need to have that prospective memory for being vigilant. Okay, now many of us have seen this picture, right? And some of you, or many of us, WhatsApp DP might be this picture. We are considered to be the masters of multitasking, but the thing is that, do we really need to boast about this? So I'm going to talk about an important concept, a really important concept known as mindfulness. Let's see what it is. See, now you are listening my talk, right? You are hearing my voice, you are seeing me. And the thing is that your body is physically present here, but is your mind actually physically present here? That is what is known as mindfulness. Your body is physically present here, but you have to bring your mind to the present. That is what mindfulness aims at. So mindful practice is awareness of external environment and as well as self-awareness. See, vigilance is just you vigilantly monitor something and you are not worried about yourself. But mindfulness is being, you think about yourself too. That is what is called as mindfulness is. Now, this is a really important uh, cognitive process model of anesthesia personnel exclusive for anesthesiology. This is known as a Rasmussen's model, and this has been mentioned in Miller. And you know that the Rasmussen's model is actually, what are the qualities that anesthesiologists need to have? So he said that the resource management quality, a good sensory motor skill, abstract reasoning, procedural skills, as well as a newly introduced component known as the supervisory control. That is, see, supervisory control is nothing but we need to have a quality known as a metacognition. That is what I have mentioned here, metacognition. Metacognition is nothing but it is just thinking about our own thinking. Just like mindfulness. See, suppose you think about vigilance is like you actively monitor the external environment, right? But during that monitoring, you think about many things, right? And that thinking about your thinking is called as metacognitions. It is a simple concept only, but the term is really confusing. It is known as metacognition. So you know that anesthesia is a area which require a dynamic thought process. You need to know about you have to be really vigilant about the blood loss, the duration of surgery, muscle relaxant, depth of anesthesia. So these are all a dynamic thought process. You have to think too many things. So metacognition is a way of thinking about your thinking, how you control your thinking. Okay. So the other word of metacognition is metaprocessing. That is thinking about thinking or feeling about feelings. It's an act of self-observation in which the mind attends to its own actions, including the subject who is performing those actions. So it allows the anesthesiologist to uncover areas of unconscious incompetence. For example, suppose I'm putting IV cannulas for 10 patients. And initial period I am failing. Even the 10th time I failed putting an IV cannula. Okay, so the next time what you do, the 11th time, you are being so mindful that how you place your fingers, how you palpate the veins. I become really mindful and I succeed. So the thing is that you learn from your mistakes. Only if you are mindful during your procedures or any actions, you feel that you learn from that mistake, or understand that, oh, that was a mistake that I made. Then only you feel that you get the opportunity to perform the procedure successfully. So this is nothing but what we call it as skill. Some people put an epidural just within seconds. Some people takes long time. Some people are unsuccessful. So we call it a skill, right? That you call that person a skilled person. But usually what is the thing? The thing is that, see, that person is really mindful and he knows about the mistakes that he has committed before. And how did he know that? Because during that previous procedure also, he was really mindful. This is what is called as meta-processing. You know that there are two types of knowledge. One is the explicit knowledge and a tacit knowledge. Explicit knowledge means you learn from the textbooks, the teacher teaches you, you grasp that. But Tacit knowledge is something other. That is like you learn from your mistakes, right? You observe certain things. Oh, this is a way to hold the laryngoscope. So from the textbooks, you learn that this is a way, but according to the anatomy of your fingers, your joint mobility, you also develop a particular way of holding the laryngoscope, right? So that is known as tacit knowledge. And mindfulness is really important in developing tacit knowledge. And the history of mindfulness dates back to 1500 BC in this yoga disciplines in India. But it was in around 1990s, mindfulness-based cognitive therapy was introduced in psychology. And it is in 2020 that it holds massive mainstream appeal across medicine, mindfulness. Let's see, what is the difference between mindfulness and meditation? Many of you have that doubt, right? What is the difference between mindfulness and what is meditation? See, suppose I am asking you to meditate for 10 seconds. What will you do? You will just close your eyes and you will try not to be thinking about anything, right? And at fifth second, you feel that some thoughts come to your mind and you feel distracted. And you feel that, oh, my meditation, whatever meditation I do, it becomes unsuccessful. That is a problem with meditation. But what is mindfulness? Suppose I'm just the same thing. I'm telling you to meditate for 10 seconds. So at fifth second, you develop a thought. You are getting into a thought. The mindfulness means you are just observing your thoughts in a neutral, in a non-reactive way. You just observe your thoughts how it is. So you don't feel that stress, right? So after a point of time, you feel that these are all normal and you don't get stressed. You just observe how your thoughts wander. Okay. Now, there are many mindfulness exercises that is available in the internet. Now, let me tell you some exercises. One is the body scan. Suppose you are listening to me now, right? You are seeing me. But have you noticed that where is your body now? Are you sitting? Are you standing? Where are your legs? Are they on the floor? Are they on the chair? Where is your right hand? Where is your left hand? Just keep an eye on that. Just feel that. That is what is called as mindfulness. Okay, so you are worried about what you can say, you are just vigilant about the external surroundings as well as you should be aware about your inner self too. Oh, mindful seeing. Mindful seeing means what? Suppose you look at a calendar or a clock. You should appreciate its geometry. See how the second needle is moving. You can see how well spaced the hour needles, the minute needle is. So these are all what is called as mindful seeing. Suppose if you see a portrait, you see it in detail. Okay, so these are a few of the methods that can be practiced for mindfulness. Now, what is the science behind mindfulness? It is nothing but neuroplasticity. You know that amygdala is known as emotional response center, and that after practicing mindfulness, it becomes less active. So you don't get distracted by too many thoughts. Okay. The second is that hippocampus. You know that the hippocampus regulates the amygdala's emotional responses. You don't get, so you feel that pleasant feeling of observing your thoughts, how you are. So the hippocampus becomes more active so that the amygdala's emotional responses are actually regulated. As well as it is seen that the neurons of the anterior cingulate cortex, which helps in motivation and attention, are also becoming more active due to mindfulness. Now, this is what is called as mindlessness. And you know that the multitasking, see, you can see here, the multitasking is considered to be mindlessness. I showed you the previous picture where the anesthetist is having so many, like he's performing multiple jobs, right? So that is considered to be mindlessness. And this is one of the reasons which creates stress, boredom, pain, unhappiness, errors, hurting others. These are all important tools, or what we can say, these are the important reasons for creating such things. And these are the important consequences of mindlessness. So mindfulness and patient safety is becoming a new trend. You know that multitasking, frequent distractions, fatigue, anxiety, anger, cognitive bias, haze, these all lead to poor clinical decisions, clinical errors, errors in diagnosis, errors in management. And have you just noticed that these all things are typically you can attribute to anesthesiology. You can have distractions, you can have fatigue, You have this multitasking. So that is why mindfulness become so important. There are stages of mindfulness. The initial stage include you just actively observe yourself. Let it be the patient as well as the problem. You can observe anything, but you observe only that. Finally, you find that you adopt a beginner's mind. Can understand that you can make mistakes, but it is okay, and you can move forward. And then you develop a stage of critical curiosity, that sometimes you find that whatever you are doing were really right, and now you understand that no, I have to improve, there were some mistakes in it. So that is known as critical curiosity. And courage to see the world as it is. It need not to be perfect. There are imperfections and there will be imperfections, and to accept that you need courage. You can develop with the help of mindfulness. Humility to tolerate awareness of one's areas of incompetence, as well as an absolute presence of mind. So these are the stages of mindfulness. And I would like that mindfulness be an important part of the curriculum in anesthesiology, because mindfulness principle, the present moment awareness, openness to the possibility, curiosity, reflection of ourselves, these are all important things that is to be learned uh, in modern medicine. And I would say that anesthesiology is the specialty where this needs to be actually trained. We need to be trained in that. And we have many videos regarding mindfulness practices, and we need to just 20 seconds, 30 seconds will do every day. That helps really, because I have experienced that. I had just practiced, and it brings a lot of change. And you need to bring that community of practice, individual practice, scholarly approach to teach mindfulness and to imbibe some good things from mindfulness. And I would like to say that from now on, you feel that this is no longer something to boast about. And multitasking is not always a good thing. I would say that it is not possible to suddenly stop multitasking and you go for a unit tasking, but it is nothing to for you to boast about. And yeah, unit tasking is also a good thing. And you can make a lot of difference from changing to multitasking to unitasking. It is really difficult, I know, but let this be a change, and we should start thinking about it. I just want, my intention of this presentation is just for us to just start thinking about this. And thank you for your patient hearing. And if you have any doubt regarding this topic, like, feel free to just contact me. Like, whatever I have learned, whatever I have read, I would like to, I'll be really happy in answering that. Thank you so much. And thank you so much for your patient listening. Thank you.